A very good evening to one and all. My topic for discussion today is importance of optic nerve head analysis in detecting glaucoma progression. So why do we need to examine the optic nerve? Because it is the site where the damage due to glaucoma is most prevalent or most seen. So optic nerve is nothing but a bundle of axons of retinal ganglion cells as it exit from the retina to the brain. So the goal of examination of optic nerve is to distinguish a normal optic nerve from an abnormal one. If it is abnormal, we have to distinguish glaucoma from other optic disc pathologies, and if glaucoma is present, we need to detect and watch out for progression. So the gold standard for examining an optic nerve is stereoscopic viewing with the help of a slit lamp and fundoscopic lens. It's always ideal to dilate the fundus and to obtain a fundus photograph so that we can compare it with the previous visits. So with the help of a slit lamp, we make a small vertical beam and overlay it over the disc. And the length of the beam is multiplied by the correction factor of each condensing lens to get the size of the disc. So what is a normal or a typical disc? So these are the basic characteristics. It has a normal or a vertical disc diameter averaging between 1.7 to 1.8 mm. The disc is vertically oval, whereas the cup is horizontally oval. The rim follows the Eisen rule, and the rim is yellowish orange or pinkish yellow in color. The discs are similar or they are symmetrical in both the eyes. The central retinal vessels arise slightly nasal to the center, and there are visible RNFL striations superior and inferior to the disc. So size is the first factor which we take into consideration when we examine the disc, and this is also the factor that varies the most. So naturally, a bigger disc will have a bigger cup and a smaller disc will have a smaller cup. So when we discuss about cup-disc ratio, it is of paramount importance that we have to consider the size of the disc. And also when we say that cup asymmetry is a sign of glaucoma, it is only if the discs in consideration are of the same size. So based on the disc diameter, the disc can be classified into a small, medium and large disc. So cup-disc ratio is nothing but the ratio of the vertical cup-disc diameter upon the vertical cup diameter upon the vertical disc diameter. But to identify this, we need to know what the margins of disc and cup are. So to define the margin of disc, that is done by identifying the scleral rim of Elschnig. So the optic disc actually starts from the inner border of the scleral rim. Now the cup edge or the cup border can be found out by two methods, that is by color contrast method or by contour method. By color contrast, we typically mean that there is a difference in color between the cup and the rim. The rim is yellowish orange and the cup is pale in color, so we can identify the edge using that. But a more accurate way would be a contour method wherein we trace or trail the blood vessels. So as the blood vessels come from the optic disc, they bend at the edge of the rim of the disc. So if we trace all the bends of the vessels, we will be able to get the edge of the cup. Second one is neuroretinal rim, and this is basically the area between the disc margin and the cup margin, and it is formed of 1.2 million retinal ganglion cell axons, which leaves the optic nerve head. So the rim, which is made up of axons, it is orangish or yellowish in color, whereas the cup, which is a void area, it reflects the lamina cribrosa underneath and it is pale in color. So in a glaucomatous disc, even though the rim gets thinner, it retains its color, that is that pinkish yellowish color. The only exception to this is when the disc endures an acute rise in intraocular pressure, such as in case of acute angle closure glaucoma. So rest assured, in almost all glaucoma cases, pallor is not there. And if at all we encounter significant pallor of the rim, or if the pallor is more than the cupping, we have to think about other causes of optic neuropathy. So next is the Eisen rule, which means that the inferior rim is thicker than the superior, which is thicker than the nasal, which is thicker than the temporal. So the neuroretinal rim thinning can be diffuse or localized, and a localized defect is called a notch, and when there is a complete loss of an NRR tissue, it's called excavation. So we all know that the glaucomatous rim thinning usually affects the superior and inferior poles. We do not come across a nasal or temporal notch superiorly. So why is it so? The answer lies in lamina cribrosa. So this is the cross section of the lamina cribrosa, and it has fibrous tissues called the glial cell which support the axons. So if you look at it closely, the pores in the superior and inferior area, the pores are larger. The size is larger, which means the support to the axons are less, which means the axons becomes more susceptible to the damage due to rise in intraocular pressure, resulting in a notch superiorly or inferiorly. So as far as progression is concerned, there will not be any change in the size of the disc, but there will be progressive increase in the size of the cup or the cup disc ratio. Why? Because there is progressive thinning of the neuroretinal rim, initially maybe in the form of unipolar notch, followed by bipolar notch and an excavation of the rim. The next one is the retinal nerve fiber layer. They are nothing but refractive striations extending radially from the disc. They are thickest and most visible superior and inferior to the disc. So when we visualize them in a red free filter or a green filter, they are seen as white lines against dark background because these thicker striations reflect the maximum amount of light. So the RNFL defects can be slit defects, wedge defects, or diffuse defects. Diffuse is anything more than 30 degree. Again, when we look out for progression, we have to look out for progressive enlargement in the size of the RNFL defect and also development of a new RNFL defect. So there are many vascular changes with varying degree of importance when it comes to glaucoma. We will discuss a very few of them. So first one is called the bayoneting of vessels. Bayonet is nothing but it's like a knife or a dagger which is attached to the end of the rifle so that the soldiers could defend themselves. So this is the normal arrangement of vessels in the optic nerve. This is how the central retinal vessels comes out through the optic nerve. But when there is a cupping or deepening of the cup, these vessels will have to take an acute bend at the edge of the thinned out NRR. This is similar to the bending or kinking seen in bayonet, which is why it is called a bayoneting sign. Next is bearing of circumlinear vessels. Circumlinear vessels are small vessels which are branches of central retinal artery that runs along the rim of the edge of the cup. So when there is an enlargement of the cup, this circumlinear vessel stays in that position, whereas the cup margin will recede further. So this will make the vessel look bare or exposed or as if it's lying on the surface of the disc. This is called bearing of circumlinear vessels. Nasalization of vessels is not very specific to glaucoma. It can be seen in normal discs also. Next is disc hemorrhages. They are basically splinter hemorrhages seen usually in the superior temporal or inferior temporal quadrant. They usually resolve within few weeks to months, and when they resolve, it's usually associated with a new RNFL defect or an early notch. So in a diagnosed case of glaucoma, if we encounter disc hemorrhage, it is a strong predictor for progression of glaucoma. So while analyzing the vessels for progression in glaucoma, we have to carefully look for shifting of vessels because vessels shift only when there is a thinning of neuroretinal rim or there is an enlargement of cup. So documentation using fundus photo is of paramount importance in glaucoma. So in presence of a disc hemorrhage or trans hemorrhage, we have to watch out for RNFL defect or an early notch. The next one is peripapillary atrophy. There are basically pigmentary changes in the peripapillary area around the optic disc. There are two zones, the outer alpha zone, which is not specific to glaucoma, and an inner beta zone, which is specific to glaucoma. Normally seen in open angle glaucoma and normal tension glaucoma. So in progression, we have to look for progressive enlargement of the beta zone of peripapillary atrophy, and it's more common in myopic glaucomatous discs. So to summarize, these are the 5 R's which are important in the optic nerve head evaluation, which are the scleral rim, neuroretinal rim, retinal nerve fiber layer, region of peripapillary atrophy, and retinal or optic disc hemorrhage. There's also the concept of disc damage likelihood scale, which was put forward by Spaeth. This is a method of estimating the risk of glaucoma damage in an optic disc. But here we take into consideration the disc diameter and the thinnest rim width. So it is not basically cup disc ratio, it is rim disc ratio which is taken into consideration here. So what are the features of glaucomatous disc? It will have a large cup disc ratio for a given disc size. There will be an asymmetry of cup disc ratio between two discs given the size of the discs are same. There is NRR thinning. The cup becomes vertically oval. There is violation of Ising rule of the rim. There is vessel changes, there is loss of RNFL reflex or a defect, and there is presence or progression of peripapillary atrophy. The signs of progression are progressive increase in the cup disc ratio, changes in the NRR contour such as development or enlargement of a notch, shift in position of vessels, recurrent disc hemorrhages, progressive changes in RNFL defect, and enlargement of beta zone of peripapillary atrophy. Thank you.
Thank you. Thank you, Dr. Renu, for the insightful talk. If you have any doubt, you can keep the question to the last. Now I invite Dr. Shweta K, glaucoma and phacosurgeon, Jyotis Eye Care, Kannur, for her talk on importance of OCT analysis in detecting glaucoma progression. Over to you, Dr. Shweta.
Thank you, Manju. At this outset, I would like to thank you for giving me this opportunity for this presenting. So my talk is role of OCT in detecting glaucoma progression. Finding the progressive changes in the RNFL and the ganglion cells are always a primary challenge in those who are treating the glaucoma patients. We know the glaucoma continuum, where you have the apoptosis, then the ganglion cell death loss, and RNFL changes. Then comes the detectable RNFL changes. Then only comes the visual field changes, early, moderate, severe, and then to the blindness. Generally, what we see is once a patient is coming after the functional impairment. But what we need to find out is diagnose a patient once it is in the asymptomatic or undetectable stage. Also find out whether the patient is progressing in this asymptomatic stage. Now, what are the advantages of OCT progression analysis in glaucoma? It is objective and fast, and the structural progressions do precede the functional progression. And you can have high reproducibility with low test-retest variation, and can detect progression at a pre-perimetric state. And it evaluates the optic nerve, RNFL, and the macula at the same time. So what are the basic concepts in structural progression analysis? We need to have a proper good image registration. What it means that the baseline image what we take, that should be properly aligned, and it should be a good image. As only then we can have a next follow-up scan which should have a good reproducibility, and there should be dynamic, useful dynamic range, and there should be an agreed definition of progression and ability to differentiate glaucomatous and non-glaucomatous stage. We all know that visual fields are something which used for the progressive analysis, but now recent OCTs which have come recently are giving us more insights into the optic nerve head and RNFL changes and even the macula changes, which can detect even earlier. Now, generally when you have progressive analysis, you have the trend analysis and event analysis. Trend analysis is nothing but you see the trend, how it goes, multiple tests are taken and how the trend line is, whether it's going down or not. Event analysis, you compare with the baseline, and if you get any change, that is shown. So generally the prerequisite is you should have an eye tracking in OCT, accurate alignment of scan, measure relative, a stable landmark should be there, and you have to align the RNFL circle. So I'll be discussing two OCTs, the spectralis OCT progression analysis and the cirrus OCT progression analysis. The first one which I am using is a spectralis OCT analysis. I do not have any financial interest. So generally we know that the light falling on the retina goes to the retinal photopigment epithelium, then goes to the bipolar cells, the ganglion cells, and then this forms the RNFL. So where we are interested is in neuroretinal rim, the RNFL and the ganglion cell, all three together. So this is where we have to focus on in case of diagnosing OCT as well as detecting the progression. Now in spectralis, what we have is there is a dual beam true track. You can see that there are two reference scan and a cross-section scan. So whenever the patient is moving his eyes, or if the patient is tilting his head, the machine detects it and it aligns it so that only the same area is going to be taken next time. Because we know the eyes are all different. The optic disc and the fovea, it's not always in the horizontal plane. We can have patients who have fovea little downwards and also up. There can be wide range from -17 to +6 degrees. So only when we plot this fovea and the optic disc, we get the exact orientation of the temporo-superior fibers and the temporo-inferior fibers. For example, if you see this, without APS, the temporo-superior fibers, so if you take this in the second picture, if that orientation is not seen, What we measure as temporosuperior can be tempronasal if the fovea is aligned little lower. So only if we, with the automatic positioning system only, we'll be able to see this. So in this particular device, what they do is there will be fovea detection is done first, then the fovea confirmation is done, then the Brooks membrane opening detection is done, and then we give the confirmation of the Brooks membrane. Only after this is what they take the scan. So this is the first image. The image registration, what they do is they take the fovea BMO axis and the fovea, and then only the follow-up scans, they don't do the same. Only the follow-up scan is done because already fovea and BMO axis is marked. So you can see that whenever the patient is tilting the head, you can see the scan line is also getting tilted. Why I'm showing this is, we generally tend not to take OCTs for progression analysis, but here we can get little more accurately the findings. Now I'll show the change reports, whatever is there in this. First is the RNFL change report. So you can have, whenever you get a report like this, initially you have to go to the system and see whether the segmentation is proper, whether the patient's age is given properly or not. Because the first thing here, patient demographics, according to that, we have to give the proper age because it is compared to the age mesh data from the normative database. Then the second is the IR image here. You have the sectoral as well as the TSN90 graph. Then when the baseline scan was done, and what was the quality of the scan, that is really important. Here it is 29 in spectralis, 25 up 30, 29, 30 is normal. Then you have the RNFL thickness here. This is a baseline. And when you take the follow-up scan, the same graphs, you can see when the follow-up was taken and what is the quality of scan. And you can see that whatever changes are seen are marked there, color-coded. Red indicates thinning, green indicates thickening. So generally we don't have any thickening in glaucoma. So whenever you see thickening, you have to look for some other causes. So the third image which was taken later on, you can see that here you can see at 9, if you see in the temporoinferior region, you can see the red region. These are significant decrease in the RNFL there. Then RNFL can also have a trend report. So trend report will have patient demographics we have to see. Here what you see is the global RNFL changes, the temporosuperior, temporoinferior, nasal inferior and nasal superior. Each separately they'll give us the trend. And the next area where we can focus is the sectoral areas. There you can see what are the changes that are from the baseline, whatever changes is there is shown as in the fifth one. So any change of 4 to 5 micron is considered significant in RNFL. Next is the RNFL progression trend analysis. Here the RNFL progression, you can see at least there should be at least minimum of 3 examinations for us to have the trend line. But here if you have to get the p-value and the trend, what is the rate of change, we need at least 5 examination values. So here what you see is the image quality initially. The second, the green line shows the normal RNFL range. And then you have the trend line there, which is shown in blue dotted region, and then slope of the RNFL. And each sectors can be seen separately. Temporoinferior, superior, nasal superior and nasal inferior can be seen separately. And finally, you have the minimum rim width and RNFL 3 scans, 3.5, 4.1 and 4.7 scans are there. Each you can take and it has to correspond with each other. So this is another example where you can see there are more number of examinations, around 7 examinations, and it has given a dark blue line. And what is important here is you can see that it's in the white zone. White zone is a normal RNFL thickness. But if you see the trend line, even if the RNFL thickness is in the normal range, there is definite progression, definite downward progression of the RNFL. And there is a wide range of normal RNFL thickness. So another example, this is the normal range. And okay. Next comes the MRW progression trend analysis. Even the minimum rim width also, you can see the trend analysis. So you have to see, the trend shows that after how many years the patient can go into the red zone, which will, and next is the posterior pole retinal thickness change report. So MRW is measuring the NRR. RNFL, and next is the macular change. So posterior pole retinal thickness change report, this is a posterior pole which is seen, you can see the retinal thickness in the left area, and the 3 is the baseline image, and 4 is the current examination, and whatever is seen in 5 is there, if there is any change in the macular thickness from the previous, that is what's shown in 5. So here one example I'll show here, the RNFL, if you see the lines here, there are 2 lines, the darker one is the current examination and the light grey region is the baseline. So you can see in the temporo inferior area there is significant reduction and dip into the red area. And if you see the posterior pole, you can see this, whatever is in red is shown as thinning. So there is significant thinning in superior and inferior RNFL region. And we generally say that OCT, we do not use it for a floor effect. But when you see the RNFL is something which we cannot use once there is a floor effect. But if you see the ganglion cells, all these cases are 0.9 cupping and the patient is having significant visual field loss. But if you see the first 2 images, you can see that there are a little bit of ganglion cells left in that. So if you take the ganglion cells and see whether there is any significant change in ganglion cells, we get a very good idea of whether the patient is progressing or not. So just taking the ganglion cell can help in advanced disease. So macular measurements have lower floor than RNFL. But in case of artifacts, we generally cannot use the OCT progression. So these are all the artifacts. Then I'll just show about the Cirrus guided progression analysis. So here you have the baseline scan and the follow-up scans are shown here. And any change from the baseline scan is shown in 3, where red indicates that there is significant change from the previous, and even the orange indicates a significant change. Red shows there is the same change has occurred in more than 2 or 3 scans. It shows as red. So red is likely loss. If it is given as lavender, it's possible increase. And then there is also trend analysis which shows the average RNFL thickness, superior RNFL thickness, average cup to disc ratio, and inferior RNFL thickness. It is these are also color coded. So black, there will be no change. The dots are color coded. If there is black, that is no change. Orange is beyond expected, and red is significantly thin. So so you can see another example where there is a significant linear trend. So trend analysis, another example, most patients of glaucoma, the first sign of progression is observed in the inferior quadrant. So you have to focus on that inferior quadrant. And you can have the RNFL thickness profile here, similar to what I showed before, and any changes in will be shown as red. So these areas we have to be careful. And also at the end you have RNFL and ONH summary here, whether there is any significant progression or not. If there is significant progression, it will be given as a red tick. And guided progression analysis, whatever they have used for the linear and event analysis, the summary is given in box 2. And finally, the macula also has a guided progression analysis in Cirrus OCT, which has similar maps of average. Here it is GCL IPL thickness. There it was, we can see separate. In spectralis, you can see GCL separately. Here it is together GCL and IPL. So similarly, you have the trend analysis. So detect early progression and prevent irreversible vision loss in glaucoma. OCT can definitely be used in glaucoma progression analysis. So thank you.
Thank you, Dr. Shweta, for a very detailed and elaborate presentation. Next, I call upon Dr. Manju, a glaucoma surgeon from Arya IK Thrissur, on her topic, role of visual field analysis in detection of glaucoma progression. Over to you, Manju.
Good morning. The tracking of glaucoma progression, a deep dive into the visual field analysis. Let's start with the basic question. What is glaucoma? It's not working. What is glaucoma? Glaucoma is defined as a disturbance in the structural or functional integrity of the optic nerve that can be arrested or diminished by adequate lowering of IOP. So in glaucoma, there is a chance of a progressive optic neuropathy. So the goal of any glaucoma consultant or glaucoma physician is to detect and manage glaucoma progression. So how to detect progression? It's by the structural or functional analysis of the glaucoma. Structural analysis is done by the optic nerve head analysis and OCT analysis, which is already covered, and the functional analysis is by the visual field analysis. So as a normal visual field is defined by the trachea as a hill island of vision surrounded by a sea of darkness. It's around 60 degrees superiorly and nasally, 70 degree inferiorly and 100 degree temporally. And blind spot is a physiological absolute sclerotoma, that is 10 to 15 degree temporal to fixation. And there is a frequency of seeing curve. Basically what is threshold is intensity of the stimulus, which when presented at a particular location n number of times is detected at least 50% of the time, and that is the threshold. And perimetry is basically the systematic measurement of the visual field, and we use usually standard automatic perimetry or white on white perimetry, that is most commonly used, and that is a static perimetry. And we use normally CETA setting that uses prior distributions of normal and glaucomatous visual field behavior to estimate threshold sensitivity. And the usual parameters that is used is a Simulus 3 white with a fixation target central, that is a usually used testing program. And there are testing programs like 30-2, which uses 76 points 6 degrees apart. 24-2, which is usually used in glaucoma, involves 54 points 6 degrees apart. And 10-2, 68 points 2 degrees apart, and the macular threshold 16 points, that is 2 degrees apart. And there are other testing programs like 24-2, which involves an additional 10 test points, that is at the central 10 degrees, which can gives early involvement of central points. So according to these are the Anderson criteria. There are two important points regarding the Anderson criteria. It considers only the non-edge points, but in case of if you are taking 24-2, we have to involve edge points also. And also it should be done or analyzed in 2 consecutive fields. So there are some scotomas that is usually seen in glaucoma. One is a paracentral scotoma if it involves central 10 degrees. Nasal step, which is usually a early involvement, that is a relative depression of one horizontal hemisphere. Then there is arcuate scotoma or Jerem scotoma. And threat to fixation that happens in advanced glaucomas if there is any one of the central points in a 24-2 field is involved. If there is any threat to fixation, it's better to do a 10-2 field to see whether there is any involvement of fixation, that is if one of the central points in 10-2 is involved. And also there is if there is a threat to fixation, it's important to do macular program to see whether there is any macular split. If there is 2 out of 4 central points with a sensitivity of 0 decibel, or if all the 4 points in one quadrant have a 0 sensitivity, 0 decibel, sensitivity of 0 decibel, you say that there is a macular split. That's most commonly done before any glaucoma surgeries. And see for any artifacts. One is a rim artifact, usually due to the correction that is given during the field testing. And there is chance of high positivity. If the patient is a trigger happy patient, you can have high false positive reports with white scotomas, and the lethargic patient may give a high false negative or a cloverleaf pattern kind of fields. So see for any artifacts. And most important, before detecting any progression or analyzing for a progression, important to have a structure function correlation. Like you have to take the structural, that is OCT, and see whether your field report corresponds to that of the OCT, to see whether there is any there is structural function, proper structural function correlation. As in this case, the OCT analysis is both the eyes are normal, but there shows a field defect. So when we repeated the field, this patient didn't have any field defect in the left eye. So it's important to have a see whether the patient is having correct structure function correlation. And same as in this case, it gives a full report where this is the patient's disc photo, and this is the RNFL defect, and this is the ganglion cell complex analysis. So the machine itself predicts that if the patient is having an RNFL defect in this region, where can be the field defect in this patient. So if there is an RNFL defect in this region, there can be a field defect in this region, the machine is predicting. So we are doing the visual field analysis in the HFA machine, and as the machine predicted, the patient is having a field defect in the same location. So there is a good structure and function correlation in this patient. Now coming to the progression analysis. So what is basically progression? There can be a deepening of scotoma, enlargement of the existing scotomas, and appearance of newer scotomas. So many prerequisite for the guided progression analysis, which was almost similar to that of the OCT analysis, there should be a baseline visual field testing, and it should be better, preferably post-learning curve. The patient can have some learning curve. So if the baseline reports are post the learning curve, it's better. And there should be a consistent testing condition. If you are testing the patient in one condition, it should be tested, all the fields should be tested in the same condition, and reliable, the data should be very reliable, and regular testing schedule, at least 5 testing schedules should be within the 2 years if possible, and patient cooperation and compliance is very important in this case. So this is the guided progression analysis given by the machine. There should be a minimum 5 fields, same as OCT. There are 2 baseline field and 3 follow-up field, and the report will have the 2 baseline field in the upper part, and this is the current field, and the machine will itself give the trend analysis, like if the patient is having the same rate of progression, what can be the patient condition after 5 years. That is the trend analysis that is given by the machine. This is the rate of progression of the patient. So these are the visual field index is there, mean deviation is there, all it is written, and you can have progression analysis either by the visual field index or the mean deviation, and the visual field index of all the visits will be recorded, and the machine can extrapolate this data over 5 years and tell us that if the patient is having the same rate of progression over 5 years, what can be the patient's visual field index after 5 years. So it can tell you whether you need more intervention at this point of time. So that is what is called a trend analysis based on visual field index, or can be based on mean deviation also, to quantify any observed rate of change and to assess the risk of future visual disability. That is the most important one. Can give the risk of future visual disability if this rate of progression is the patient is having the same rate of progression. So what will happen over 5 years if the current rate of progression continues? So this patient was had taken the first visual field and second visual field, and the patient lost follow-up for some years, and now this is the patient's visual field. So if you extrapolate the data over the 5 years, the patient is going to go blind. It's almost 0. So if the same rate of progression is happening to the patient over 5 years, the patient is going to become blind. So it's the patient machine or the program is practically telling you need to do some intervention, either increase your medication, do a laser or surgery. You need to do some intervention to reduce the rate of progression at this point so that the vision can be preserved for the patient. Almost the same, and there is one more thing. If you change your management protocol, or if you do some trabeculectomy, or if you do some glaucoma surgeries or laser procedures, you need to change the baseline field after that. So here the patient was having this rate of progression here, and then a surgery was done. Now we have changed the visual field, baseline visual fields. Now these after the surgery, the first visual field that we take will be taken as the first baseline visual field, and then after the procedure, what is the rate of progression? That's what next we will calculate. So if you do any intervention, you have to change the baseline visual field after that. There is also event analysis to assess whether there has been a significant worsening from the last field or from the baseline field compared to, that is, event analysis is in comparison to the stable glaucoma patient. So if there is any 5% deterioration, it will be given as an open triangle. And in the next, or the consecutive field, there is again a 5% deterioration, you will have a half-filled triangle. And in 3 consecutive fields, you are having a 5% deterioration, you will have a full-filled triangle. So if there is a, if you cannot, after that, if there is any progression, it's out of the range, or the machine cannot calculate the progression after that. But there is one thing, it should be consecutive field. If you don't have a progression in the next field, it will again go into the first open triangle. So, and based on this, the machine can give you reports like possible progression. If same point, there is deterioration in the same point in 3 consecutive visits, significant deterioration, sorry, in 2 consecutive visits is possible progression, and 3 consecutive visits, if there is a deterioration at the same point, it's like a likely progression. So here in this patient, at this point, there is an open triangle, this is a half-filled triangle, and there is a full-filled triangle. So the patient is having a same deterioration at the same point in 3 visits. So there is a possible progression, and second is a likely progression. So event analysis is important that you should have a consecutive fields. And there should be at least 5 fields. So if you have only 4 fields, there is only, you can't get that extrapolated data, but by looking at this, you can see that there is a decrease in the visual field index. It was like here, and now in the follow-up visit, the patient's VFI has reduced. So, but only if you have 5 fields, you will get the extrapolated data. And there is, according event analysis, you can have reports like likely progression. And there can be a learning effect. In this patient, the final visual field is better than the previous one. It can be due to learning effect. So it's better to negate learning effect before taking the baseline visual field. And in patients with advanced field effect, it's always better to do a 10-2 field. So the future dimensions are, there are AI or ML algorithm which can detect even subtle pattern and give you early signs of progression. And there are data collected from the visual field, OCT, Octa, and even genetic information that can increase the accuracy of this diagnosis. And there are many longitudinal studies that are going on regarding the tracking pathogens and progression, which may help us to have a personalized or tailored treatment plan for our patients. So the take-home messages are, OCT and visual field are complementary diagnostic tool. Early detection, which helps in the early detection and monitoring, and to calculate rate of progression and to plan early intervention. But there can be an individual variability, and clinical correlation with other factors are important. Thank you.
Thank you, Dr. Manju, for simplifying such a complex topic. Next, I call upon Dr. Manju Anup, a senior glaucoma surgeon from Giridhar Eye Hospital, for her talk on management of glaucoma progression. Over to you, ma'am.
A very good afternoon to all. I'll be talking on management of progression in glaucoma. Detecting the progression and modifying the treatment at right time is very important in the management of glaucoma. We have already seen various methods to assess the progression, and once you have documented a progression, the next step is confirm the progression. For that, you need good quality test and reliable test. And before confirming the progression, you need to look at the relation of the progressing location to the original location. Because in glaucoma, usually the progression occurs adjacent to the original location. Then look for accompanying clinical evidence. In case of any doubt, repeat the test. Now, you have confirmed the progression. What next? Whether you have to treat the patient or you have to observe and continue with the current treatment. For that, we should understand that aim of glaucoma management is to slow down the progression to an extent that minimizes the likelihood of glaucoma-related visual disability and quality of life during the lifetime of the patient. So if you feel that this amount of progression is not going to affect any of the above factors, then you don't have to treat that progression. You can continue with your current medication and re-evaluate, and whenever you feel a higher rate of progression, then you can think of treating that progression. So once you have decided to treat that progression, then you have to look at the relation of your office IOP to the target IOP. Suppose you have not achieved the target IOP when the patient is progressing, then you have to look at the compliance. You have to ask the patient whether the patient is using the medications every day at right time, whether they are missing the drops in between, and you can even ask how many bottles they have purchased since the last visit to look for the compliance. Also, make sure that the technique of instillation is proper. Always do a gonioscopy whenever you see a progression, because the angles might be getting closed and that may be the reason for a progression. The another scenario is you have achieved your target IOP, even then the progression is occurring. Then you have to again look for the compliance, rule out other secondary glaucomas which could cause transient intraocular pressure fluctuations like uveitis flare-up or steroid usage, and rule out other ocular pathologies that can mimic glaucoma progression like vein occlusion, arterial occlusion, retinal scar, ARMD, etc. Again, gonioscopy is very important, and then do a diurnal variation of tension, if possible 24 hours, to look for any pressure which is going up beyond your target IOP outside the office hours. Also look at some systemic factors. You have to ask for specific yoga postures, whether the patient is doing any Shirshasana, which can cause progression. Then use of wind instrument. Sleep apnea, many studies have found that sleep apnea has a very good, very strong association with glaucoma. And next is you have to look for any nocturnal hypotension, especially when the patient is a hypertensive and using the antihypertensive medication at night. So for which you may have to do a 24-hour BP monitoring and rule out a nocturnal hypotension. If the patient is on antihypertensives at night and you find out a hypotension, then you have to ask the physician whether they can change the medication to morning or at least to evening. Look for any evidence of reduced ocular perfusion, for which you may have to do a carotid Doppler, neuroimaging or cardiac evaluation. So once you have ruled out everything and you find that there is still a progression which you have to treat, then you have to augment the therapy. So before deciding what next, you have to consider following factors: that life expectancy of the patient, rate of progression, severity of the disease, and the number of AGMs which the patient currently on. Suppose the patient is an elderly patient, slow rate of progression, mild to moderate disease, and patient is only on 1 or 2 medications, then you have to think of a medical or laser procedure. Suppose the patient is on single drug, which is a beta blocker or carbonic anhydrase inhibitor or an alpha agonist, switch to prostaglandin agonist because it gives further IOP reduction with single drug. If the patient is already on a prostaglandin analog, you can add another drug, maybe a beta blocker, and you can give a fixed dose combination. You can try laser trabeculoplasty also. And if the patient is young and he is a fast progressor and it's an advanced disease and patient is already on maximum medical therapy, then you have to consider a filtering surgery. In case of angle closure, you can consider a YAG iridotomy or a cataract surgery. We'll just look at 1 or 2 cases. This is a 78-year-old male who had undergone YAG-PI in both eyes and on an AGM after that. Later he underwent cataract surgery and he had a pseudo-exfoliation in the right eye. So patient was on 3 anti-glaucoma medications and the left eye was primary angle closure disease which was stable, and the right eye he had PXF and the intraocular pressure was 18. and the patient is already on 3 medication with an advanced damage. So his fields were showing progression, which was confirmed with imaging, which was also showing progression both in RNFL and the GCL. So considering the advanced damage and the patient is already on maximum medical therapy, the patient was advised a filtering surgery. This was another lady. She was 69-year-old female. She underwent YAC-PI in 2018, and following YAC-PI, her angles were open with a few peripheral anterior synechiae, and her intraocular pressure was 18 millimeters in both eyes without any anti-glaucoma medication. Fields and OCT were done in 2019, which were normal, and the central corneal thickness was 520. This was her fundus picture in 2019. Then she lost for follow-up with us because of COVID time, and then she reviewed in April 2024. She was not on any anti-glaucoma medications, and her intraocular pressure was 22 millimeters at that time. Gonioscopy was same. So this was the picture in 2019, and in 2024, both the discs were showing advanced damage with RNFL defects, and intraocular pressure was 22 millimeters. Her fields and OCT were showing significant damage in both eyes, and she was started on prostaglandin analogs. Her intraocular pressure had dropped down to 14 millimeters of mercury in both eyes. Then after 6 months, she was reviewed in November 24, and her intraocular pressure on diurnal was maximum was 16 in the right eye and 18 millimeters of mercury in the left eye. However, her fields and OCT were showing minimal progression in the right eye, but there was a significant progression in the left eye. So we ruled out all other causes for her progression, including MRI, carotid Doppler and VEP, all were within normal limits. So considering her pressures in the high teens, we reset our target IOP and added brinzolamide eye drops. However, there was not much reduction in the intraocular pressure, so I changed the medication to brimonidine. So now she is on brimonidine with prostaglandin analog. She is yet to come for the follow-up. So before deciding to augmenting therapy in progressive glaucoma, you have to confirm the progression, assess the rate of progression, assess the severity of the disease, and consider the life expectancy of the patient, because our aim is not to treat just the intraocular pressure, disc or field, but to treat the patient as a whole so as to provide maximum benefit with minimal side effects. Thank you.
Thank you, Dr. Manju, for the excellent talk based on clinical scenario. Any doubts or any questions? To conclude, basically, the management of glaucoma progression is to first confirm the reliability of the test, and to confirm the structural function correlation, then to confirm whether the patient is having the progression and what is the rate of progression, and manage accordingly. Any doubts? Or usually there's one doubt I have, like there's a discrepancy in the structural and functional progression. Like there is a structural OCT, there is a progression, but visual field is like remains static, or visual field there is a progression, but OCT is like static. No, and change the management. Okay, thank you. Thank you.